Let's look into the clinical application of pharmacogenetic testing of clopidogrel. Clopidogrel is a prodrug. It has no antiplatelet activity until it is metabolized to its active form. This metabolism is mainly carried out by the enzyme CYP2C19. However, genetic differences in CYP2C19 can significantly affect how well a patient responds to clopidogrel. Some individuals carry loss-of-function variants of the CYP2C19 gene, leading to reduced enzyme activity. As a result, several clinical guidelines now recommend CYP2C19 genotyping in specific scenarios, such as before prescribing clopidogrel after stent placement or in high-risk patients. Let's break down the phenotypes and clinical implications. Normal metabolizers usually have a standard response to clopidogrel. Intermediate metabolizers show reduced activation of the drug, which translates to lower efficacy. Poor metabolizers, who carry two loss-of-function alleles, have significantly reduced drug effects, increasing the risk of cardiovascular events such as stent thrombosis, myocardial infarction, or stroke. On the other end, ultra-rapid metabolizers may have increased bleeding risks due to faster activation of the drug. The key clinical concern is this: reduced formation of the active metabolite leads to insufficient platelet inhibition in poor metabolizers, which can be dangerous. For such patients, alternative antiplatelets such as prasugrel or ticagrelor are often recommended, as they are not dependent on CYP2C19 for activation. To conclude, integrating pharmacogenetic testing into clopidogrel therapy can optimize patient outcomes, reduce risks, and guide more personalized treatment choices. Let's look into another clinical scenario of the role of genetics in drug metabolism affecting patient outcomes. A patient has just undergone abdominal surgery. In most cases, about 99% of patients, spontaneous breathing returns once the effect of the anesthetic drug wears off. However, in this case, the patient does not regain normal physiological respiration even after the surgery is over. He remains dependent on mechanical ventilation. This delayed recovery raises suspicion. The clinical team suspects a rare but important condition, a congenital deficiency of the enzyme called pseudocholinesterase. Investigations are carried out and the suspicion is confirmed. The patient has a pseudocholinesterase deficiency. So, what does this mean? Succinylcholine is a short-acting neuromuscular blocking agent often used during surgery to induce muscle relaxation. It normally gets rapidly broken down by the pseudocholinesterase enzyme in the blood into inactive metabolites. In healthy individuals, this breakdown is quick, so the muscle paralysis wears off within minutes. But in patients with pseudocholinesterase deficiency, the enzyme activity is significantly reduced or absent. As a result, succinylcholine is not metabolized efficiently. This leads to a prolonged duration of muscle paralysis and respiratory suppression because the drug remains active in the body far longer than intended. This is why our patient cannot breathe on his own after surgery. The drug's effect is still ongoing. In summary, succinylcholine requires pseudocholinesterase for metabolism. Deficiency of this enzyme leads to prolonged neuromuscular blockade. Patients with this deficiency require ventilatory support and careful monitoring post-operatively. This condition is genetic and can be tested using specific enzyme activity assays or genetic screening. For such individuals, alternative muscle relaxants that do not rely on pseudocholinesterase should be considered in future procedures. Here is another scenario. Isoniazid is a first-line drug used in the treatment and prevention of tuberculosis. Once administered, it undergoes a process called acetylation in the liver. This is a key metabolic step that determines the patient's response and risk of side effects. This process is governed by a genetic trait known as the N-acetyltransferase 2 (Na2) enzyme activity, which classifies individuals as either slow or rapid acetylators. Let's look at what this means. Slow acetylators metabolize isoniazid more slowly. As a result, the drug stays in the system longer, increasing the risk of neurotoxicity, particularly peripheral neuropathy. Rapid acetylators, on the other hand, break down isoniazid quickly. This can lead to a buildup of toxic metabolites, placing them at higher risk for hepatotoxicity. So, acetylator status can influence both the efficacy and toxicity of isoniazid. This variation is genetically determined and differs among populations. For example, a higher proportion of Asians tend to be rapid acetylators, while slow acetylation is more common among Europeans and Africans. Understanding this pharmacogenetic variability helps in anticipating adverse effects. To sum up, isoniazid metabolism varies based on acetylator status, which has a direct impact on toxicity profiles, neurotoxicity in slow acetylators, and hepatotoxicity in rapid ones.